So in this video, we will cover neoplastic disease of the stomach, specifically benign gastric polyps, including inflammatory, hyperplastic, fundic gland polyps, and adenomas, as well as malignant cancers, including adenocarcinoma, lymphoma, carcinoid tumors, and GIST. So a polyp is just a nodule or mass projecting above the surrounding mucosa. It arises from epithelial or stromal cell hyperplasia, inflammation, ectopia. Ectopia is just tissue that normally isn't found there, or it can also arise from neoplasia. The four main types of gastric polyps are inflammatory, hyperplastic, fundic gland polyps, and adenomas. These are primarily differentiated by their morphological features. So inflammatory and hyperplastic polyps combined make up about 75% of all gastric polyps. They are most commonly found in those 50 to 60 years of age who have a history of chronic gastritis. Inflammatory and hyperplastic polyps are differentiated based on the degree of inflammation present. So as the name implies, inflammatory polyps have a greater inflammatory infiltrate. They tend to occur in multiples and are ovoid in shape with a smooth surface. On microscopic exam, you can appreciate these irregular foveolar glands that are cystically dilated and elongated. The frequency in which dysplasia develops is related to the size of the polyp. So there's an increased risk of dysplasia in polyps greater than 1.5 centimeters. And here you can just appreciate those really enlarged, dilated glands. Okay, so fundic gland polyps tend to occur sporadically or in association with FAP or tuberous sclerosis, both of which are covered in the colonic polyps and colon cancer video. So when these occur sporadically, it is often the result of a proton pump inhibitor use. The reduced acidity from the PPI results in increased gastrin release, which in turn drives glandular hyperplasia. Patients with fundic gland polyps can be asymptomatic or have nausea, vomiting, and epigastric pain. On endoscopy, these appear as multiple well-circumscribed polyps within the gastric body and fundus. On histology, the glands are also cystically dilated and irregular, but they're going to be lined by flattened parietal and chief cells. And you can see the arrow pointing to an example. Gastric adenomas account for 10% of gastric polyps and are typically seen in those 50 to 60 years of age with a history of chronic gastritis with atrophy. Remember, gastric atrophy is typically the end result of chronic gastritis, where you get loss of gastric glandular cells with their eventual replacement by intestinal and fibrous tissue. Gastric adenomas affect men 3 times more often than females, and the adenomas are by definition dysplastic precursor lesions. Those greater than 2 centimeters in diameter do convey an increased risk for developing into adenocarcinoma. On endoscopy, gastric adenomas are typically found in the antrum, and on histological exam, they are composed of intestinal type columnar epithelium. Because remember, they're occurring in the setting of intestinal metaplasia. They can be classified as either low or high grade. In low grade adenomas, there is enlargement, elongation, and hyperchromasia of the nuclei. You also get epithelial crowding and pseudostratification, so everything just looks like it's being piled up. In high-grade adenomas, the nuclear atypia is more severe, and you can appreciate irregular glandular architecture with budding of the glands, cribriforming, where you're just seeing glands back to back to back, or even glands within glands. Adenocarcinoma is the most common malignancy of the stomach. It comprises more than 90% of gastric cancers. The incidence is going to vary greatly with geography, and there's a higher rate in Japan, Chile, Costa Rica, and Eastern Europe in comparison to North America, Northern Europe, Africa, and Southeast Asia. It is more common in lower socioeconomic groups and in those with a history of multifocal mucosal atrophy and intestinal metaplasia. In other words, people with a history of chronic gastritis, likely secondary to H. pylori. Patients who have had partial gastrectomies for peptic ulcer disease do have a slightly higher risk of developing cancer in the remaining gastric tissue as well. So when we talk about cancergenesis, we must first recognize that there are two different histologic subtypes of gastric cancer, diffuse and intestinal. We'll come back to this shortly, but for now just recognize that different genes seem to be involved in these two different subtypes. So most gastric cancers are sporadic and heterogeneous genetically, but mutations identified in familial gastric cancers has given some insight into carcinogenesis in sporadic cases. For example, germline mutations in CDH1, which encodes the E-cadherin protein that contributes to epithelial intercellular adhesion, is associated with diffuse familial gastric cancers and are in fact found in half of diffuse gastric tumors. Another example is the APC germline mutation in those with FAP. This mutation is associated with intestinal type gastric cancers. And in the case of sporadic intestinal type cancers, you can also get the acquired mutations in beta-catenin, as well as microsatellite instability and hypermethylation of genes. TP53 mutations are typically present in both types as well. So as we discussed in inflammatory disease of the stomach, H. pylori gastritis promotes the development and progression of cancers. And while H. pylori is the most common agent associated with gastric adenocarcinoma, about 10% of gastric cancer is actually associated with EBV infection, and this is something boards always like to test on. Bacteria known to cause cancer, H. pylori, and EBV is a virus that can cause cancer as well. So gastric adenomas, as we stated, are divided into two subtypes, and this is based on location in the stomach and gross and histologic morphologies using the Loren classification system. So you have the intestinal type and the diffuse type. The intestinal type is typically seen in those aged 50 and is twice as common in males than females. These tend to develop from precursor lesions, and as we just discussed, have genetic alterations in beta-catenin, display microsatellite instability, and have hypermethylation of genes. On endoscopy, they will appear as bulky exophytic masses or an ulcerated tumor with heaped up borders, and an example is shown here. On histologic exam, they contain abundant mucin, and neoplastic cells will have apical vacuoles filled with mucin. In contrast, diffuse type gastric cancers, the incidence of gastric cancer is pretty uniform across countries and occurs equally in males and females. Diffuse type does not develop from a precursor lesion and tends to be associated with the CDH1 mutations. On endoscopy, you can appreciate the thickened gastric wall with loss of rugal folds. This is known as linitis plastica, where the stomach takes on this leather bottle appearance due to a desmoplastic reaction that stiffens the wall. These tend to also have an infiltrative growth pattern. So instead of getting this like one large mass, it's just diffusely thickened and enlarged. On histology, you can see sheets of discohesive cells with large mucin vacuoles. These vacuoles are so large that they expand the cytoplasm and push the nucleus to the periphery, creating the characteristic signet ring cell. Prognosis is determined by the depth of invasion, extent of nodal and distant metastases at diagnosis. Gastric adenocarcinoma can also invade locally into the duodenum, pancreas, and retroperitoneum. Patients present with dyspepsia, dysphagia, nausea, weight loss, anorexia, altered bowel habits, anemia, or even hemorrhage. They're typically at an advanced stage when diagnosed, and the 5-year survival rate for advanced gastric cancer is actually less than 20%. These cancers tend to be surgically resected as current chemo regimens are minimally effective. The overall 5-year survival rate is less than 30%. Lymphomas comprise about 5% of all gastric cancers. The most common is called the indolent extranodal marginal B-cell lymphoma. In the gut, this is more commonly referred to as lymphoma of mucosa-associated lymphoid tissue, or maltoma. So carcinoid tumors are neuroendocrine tumors arising from either neuroendocrine organs like the pancreas or neuroendocrine differentiated GI epithelia like the G cells of the stomach. They occur in the stomach but are more common in the small intestine. They also commonly occur in the tracheobronchial tree and lungs. On gross exam, they form either an intramural or submucosal polypoid mass. On histologic exam, you're going to see these small, round, blue neoplastic cells that form islands, trabeculae, strands, or sheets. And these cells have a characteristic salt and pepper nucleus from all the stippling. So here you can just see sheets of cells within the organ, and in the lower picture it's just a close-up of what the salt and pepper nucleus looks like. Carcinoid tumors typically occur in the 6 decades, and gastric carcinoids are associated with endocrine hyperplasia, chronic atrophic gastritis, and Zollinger-Ellison syndrome. Patients can present with carcinoid syndrome. This occurs when the cells secrete vasoactive substances, being serotonin. This results in flushing, sweating, bronchospasm, colicky, ab pain, diarrhea, and right-sided cardiac valvular fibrosis. In order to have this syndrome, though, the tumor must first metastasize to the liver. This is due to a first-pass-like effect where the liver metabolizes the vasoactive substances to the inactive form. Thus, carcinoid syndrome is associated with metastatic disease. The exception to this is if you have a carcinoid tumor arising in the lungs. There will also be an increase in 5-HIAA, which is the breakdown product of serotonin, in the patient's urine, and this can aid in diagnosis. Patients are often treated in part with octreotide, which is a somatostatin analog that decreases serotonin production. The last tumor we will discuss today is the gastrointestinal stromal tumor, or GIST for short. This is the most common mesenchymal tumor of the abdomen and occurs around age 60. More than half of all GISTs occur in the stomach. Majority also have a gain-of-function mutation of the gene encoding the tyrosine kinase c-KIT. c-KIT is a receptor for stem cell factor. The remaining GISTs have mutations in platelet-derived growth factor receptor A. These tumors are thought to arise from the interstitial cells of Cajal, which are the cells serving as a pacemaker for gut peristalsis. In terms of morphology, on endoscopy, these will appear as solitary, well-circumscribed, fleshy masses. And on histology, you can appreciate either spindle or epithelioid cells, which will stain positive for c-KIT, which can aid in the diagnosis. So patients with GIST typically present with symptoms related to mass effect or ulceration, in other words, bleeding. Prognosis is determined by size, the mitotic index, and tumor location. These are typically treated via surgical resection. If the tumor is unresectable or if there is metastatic disease, imatinib, which is a tyrosine kinase inhibitor, can be used.